So Chris, what can you tell us about bronchiolitis, its etiology, how you diagnose it, and typical treatments?
Right, so bronchiolitis basically is congestion from stem to stern. You know, we always see the babies who come in congested. It works its way down the lungs. And it's usually congestion, if this is the trachea, the bronchi, down the bronchioles and the small airways. So it's down in here where mucus and plugging builds up. And so air goes in, it expands this, and it causes a ball valve effect, and so they get really hyperexpanded. Unlike asthma, which is more muscular and involves the bigger airways where the muscles hypertrophy and squeeze. Same thing though, air goes in and can't get out. But that's the difference between asthma and bronchiolitis, is that bronchiolitis is more mucosal and debris. Asthma is more muscular. For bronchiolitis, as you know, maybe we don't even know, but about 30% may respond to albuterol, which is why we try it. Contrary to the AAP's recommendations that we don't, there's a crossover in kids who may respond. So we do try one short nib to see if any improvement happens. Beyond that, it's supportive care. We keep the airways clean with salt water and suctioning. We recommend steamy showers at home, sleeping, having the kids sleep upright so their congestion drains down. And if they're small enough, we even have the parents, I tell the parents to have them put their kids prone on their arms and give them gentle back pats as a little chest physiotherapy. What else did I miss? So, as all of you in this camera may remember, you know, we did a big study 4 years ago using saltwater, hypertonic saline inhaled with Children's LA, and we found that actually using it in the ER seemed to increase the kids' discharge from the ER as opposed to those who were admitted. We're not sure why. There's some theories. Salt water, when it gets down to the lungs, causes the little hairs on the cells, the cilia down here, to beat faster. It also breaks up the mucus, so maybe that's part of it. So one thing we have not jumped on, but we will, is getting that more of our into more of our protocol, using hypertonic saline as opposed to albuterol. I think we'll probably still hang on to albuterol for the time being because some kids do respond to it.
So what is the criteria that you discharge, are willing to discharge these kids?
So when I talk to the residents, it's pretty simple on my little simple brain. It's are they breathing okay, and are they maintaining hydration? So breathing okay means they're not looking awfully, they're not working awfully hard to breathe. No marked retractions. They can be happy with just breathing at 60, but they can't be breathing 70. And they need to be able to tolerate fluids to the point where they're making urine every 6 to 8 hours. Their mouth is moist, their lips aren't cracked.
Is there an age limit that you typically admit versus discharge?
It's mostly those two things, the distress and hydration. The young kids, so the kids who may have RSV bronchiolitis who are below 6 weeks of age, and they're within the first day or two of illness, then those are the kids we consider admitting for the specter of apnea. About 20% of those kids are said to have apnea. We don't necessarily see that in our population, but it's kind of down where we get worried about their breathing problems. Same with the kids with pertussis.
Okay. So we treat, and going to albuterol, I know we're not talking about bronchiolitis now, but
Yep.
when you treat with magnesium sulfate, what is it that the magnesium is doing? Why are we using this?
So, if any of you in the camera there have had babies and you've had premature labor, they put you on mag sulfate to kind of relax the uterus. Mag sulfate is the same thing with the muscles around the lungs. So, if these are all hypertrophied and squeezing down, the theory with mag sulfate is that it bathes the muscles in mag sulfate, which through a series of chemical reactions relaxes the muscles, and so opens up the area a little wider. We see mag sulfate work about 40% of the time. It doesn't work all the time, and it works in the kids who have failed the albuterol treatments, who have been getting hammered at home with albuterol, come here, have 1 hour long nap, and and aren't responding. Those are the kids who we kind of tripped the threshold of starting max sulfate.
And is that essentially what's happening with Decadron as well?
And as you on the camera there know, we all have our own thresholds. I think most of us have a very low threshold for Decadron.
Mhm.
If any kid has a history of wheezing and they have a little squeak, I will give them Decadron, because you know that squeak may turn into more of a wheeze if you don't give Decadron. Decadron is really the treatment for asthma. And basically asthma, the inflammation and the squeezing of the muscles is incited by inflammation. And so if you cut the inflammation off, you're going to have a better chance of keeping these kids off albuterol and away from the hospital.
Okay. And why is it sometimes when we use albuterol, do we see a drop in, in SpO2?
Right, can you see me if I'm drawing over here?
Yes. Yes.
Okay, here's a blood vessel. Okay, so albuterol is a beta-2 agonist, and it relaxes cells, it relaxes muscles, smooth muscles temporarily. Okay, so if this is a smooth muscle, this will get wider and there'll be more airflow if you give albuterol. Same with the blood vessels, they'll get bigger and there'll be more blood flow to the lungs. So if we give albuterol to a section of the lung that is collapsed, atelectasis is what we call it, from mucus plugging and inflammation, you all of a sudden dilate, you have more blood flow going to a place that doesn't have any oxygen. So it's called mismatching. And it's temporary, and you see it up to 20, 30 minutes after the albuterol has been given, then it should resolve. And that's why.
So you generally see that abate, kind of go away?
It should go away.
Okay.
Yeah.
Can you think of anything else we should cover?
Any further differentiation between asthma and bronchiolitis?
Well, I mean, it goes back to the question of which children we decide to give albuterol to who clinically have bronchiolitis, but may have some wheezes in there, may have a family history of asthma. Let's give it a try, we say. And you know, we are hard pressed to relinquish that treatment for bronchiolitis. I think there's good reason for it, despite the AAP's recommendation last year saying don't give albuterol to bronchiolitis. It's a guideline, not a rule, and so you know, a lot of our experience says that some of these kids may respond to it. We can certainly back off on a lot of albuterol that we do give to these kids. It's a crutch right now.
Yeah. And Atrovent, what is Atrovent doing?
So Atrovent works with albuterol to augment its effect, is the short answer. And it usually works well the first dose. After the first dose, it doesn't have as good an effect as it does with the first dose of albuterol.
Okay.
Yeah.
Okay.
I think
I think we're good.
Okay.
Okay.
Thank you,
Right
Chris.
now.
Thanks, Chris.